and thanks to the other presenters. I appreciate Providence inviting me to present the data here. So we've heard about posterior cervical fusions in the traditional sense and how terrible they have been, loaded with complications and potentially very difficult on patients. And then we've heard about ACDFs and how they could be a good procedure, but yet oftentimes can be problematic in terms of pseudoarthrosis and getting the full healing potential for patients, particularly in our high-risk patients, multi-level surgery specifically. So I've been asked to present the data from the FUSE study. The FUSE study was basically started for this exact purpose, to look at how can we make ACDF a better procedure in our high-risk patients. And of course, it highlights the chorus posterior cervical stabilization system. So the FUSE study really shows excellent level 1 data that really has been eye-opening for me and a lot of other surgeons in terms of really how not good ACDF can be in our high-risk patients. When you look at ACDF in general, most surgeons will tell you it's a great procedure. You can, I hear lots of surgeons talk about you can fuse the cervical spine by spitting in it. That actually is not true when you're talking about multi-level surgery for sure. So the population of ACDF patients can be divided in two. There's your low risk patients, which are your 1 and 2 level surgeries. They're younger, probably low comorbidities. And then talking about the more high risk patients, which are our smokers, our diabetics, some other medical factors, but then multi-level, probably one of the more important risk factors for having a potential bad outcome, right? When you're talking about patients that are undergoing 3 and 4 levels of fusion, there's a much higher rate of non-union, more complications, and overall less satisfactory results for everybody involved. And this high-risk patient population ends up being about 30% of all ACDFs. When you look at the data supporting this, there's been multiple papers that say, the more levels of fusion that you're working on, the higher the chance that you're going to end up with a pseudoarthrosis. And so a 3-level ACDF, the data shows that the ACDF in those cases has a 3 to 10 times potential pseudoarthrosis rate. And so that's pretty significant, especially when you consider the fact that a lot of these patients are going to have to undergo an additional surgery. And so 35% of your 3 and level ACDFs are going to have another surgery within a couple of years. And a lot of those are not just adjacent levels, they're going to be for a pseudoarthrosis, which is problematic. So again, talking about the FUSE study and what it's about. So the objective was to look at the chorus PCSS system and evaluate not only its safety, but the overall results in a 3-level ACDF model. Prospective, multi-center, randomized. We had 18 centers involved, and I was lucky enough to be one involved in it. I've been using the Providence system here for several years now and had excellent results. And so for me to participate in this study made a lot of sense for me. And I was happy to do it. We included all patients that needed a 3-level ACDF from C3 to C7. And importantly for the study, we took all comers essentially. We wanted patients that were not only high risk because it was a 3-level ACDF, but we had smokers, we had diabetics, we had patients with osteopenia. We really didn't limit age. I think there might have been an 80 years old might have been the cutoff. But basically, we took all comers into this study. This map shows the geographic distribution of all the different centers, a good mix of some of the higher academic centers, and then some centers like myself that are in private practice, with real world patient populations. So again, the study itself was the control group, an ACDF of 3 levels, plated using instrumentation and using allograft spacers with DBM. So no, higher level bone graft, BMP, that kind of thing. It was all just DBM with allograft spacers. And then the study group was the ACDF plus the Chorus posterior cervical stabilization system. And we've already learned about exactly how the system works from Dr. Lemons. This is a picture of it here, and then obviously the set that goes with it. Everybody in the study was well versed on how to use the instrumentation. The study was looked at 2 points where we're looking at 24-month data, but we also looked at the interim analysis where we had our first 100 or so subjects get to the 12-month mark. And so I'm going to show some of that data now. But overall, we've got 227 patients within the study. So a fairly large patient population with comorbidities and across 18 different centers. When you look at the all-comer patient population that we enrolled, there really was no difference between the two groups. The posterior cervical group and the ACDF alone group all had the same age, essentially, same BMI, smoking status, diabetes. The primary and the secondary endpoints of the study are kind of the key. First, the primary endpoint, we were looking at fusion success at 12 months. And this was evaluated by a third-party radiology group to make sure that we were getting bridging trabecular bone across end plates and less than 2 degrees of motion on flexion and extension. And we looked at, again, the first 100 subjects when they hit that 2-year mark for some interim data. The secondary endpoint was showing non-inferiority on what we call composite safety success, which is a mixture of not only getting a solid fusion, but also having good patient outcomes. The neck disability index improvement, neurologic status improvement, and then we've specifically looked at whether or not patients required a secondary surgical intervention, or SSI, not to be confused with an infection. And so when we look at the fusion rate that we saw in the FUSE study, it was actually pretty remarkable and eye-opening. The difference between the ACDF group and the posterior or circumferential cervical fusion, which is the CCF group, was pretty significant. A major difference between it, a 47% difference in fusion success at 12 months, and then the patients that we had for interim analysis at 24 months, a 41% difference. Pretty low fusion numbers for 3-level ACDF in the control group, which is quite interesting and, again, eye-opening. And there's going to be a lot of discussion regarding that. We have a lot of upcoming papers that are kind of discuss how we came to these results, but there really isn't a whole lot of data on 3-level ACDF. And so this paper really gives us quite a bit of information to look at, not only as it relates to the Chorus system and how well it did, but also how crappy maybe our ACDFs have been over the years. So when you look at the primary endpoint, I mean, it was met with success completely. Not only was the composite fusion success better, but when you look at all the other indicators, essentially the circumferential group with Chorus was much better all across the board. When you look at the fusions, the ACDF group had a 46% fusion failure at 1 level. 19% of the patients had a fusion failure at 2 levels, and 14% had a fusion failure at all 3 levels. When you look at the circumferential group, it was only in 1. So that's pretty significant to me, to show that there's a big difference adding this minimally invasive tissue sparing posterior approach to the overall fusion construct. When you look at the secondary endpoint, that also was met. This is, again, looking at not only the fusion success, but also the patient-specific things. Neck disability success. Neurologic success was kind of interesting in that the ACDF group also did well, which we know that from our patient population as well. But then perhaps the biggest thing was the absence of the secondary surgical interventions. And so when you look at these subsequent surgical interventions, which is additional surgery these patients had to undergo, in the circumferential cervical fusion group, only 1 patient had to undergo any additional surgery, and it was a removal. In the ACDF alone group, there were 23 patients, and this is, again, at the interim analysis, 23 patients required additional surgery, and 21% of those, that's 21% of all ACDF patients in the study. for that intramural analysis. So pretty significant numbers there. When you look at adverse events, the vast majority of the patients in the CCF group didn't have any serious adverse events. All studies are going to have some adverse events. The way the studies are designed, things get reported. But as far as serious adverse events, which is really what matters, very few patients needed anything different in the study group, but in the control group, quite a bit. Actually, 24% required or reported an SAE. And those of us who are involved in research, that those are the things you're hoping to avoid. So there was 5 times more subjects in the control group having these SAEs. When you look at the patient-reported outcomes in the FUSE study, as expected, everybody did reasonably well. But interestingly, the CCF group, which is the circumferential cervical fusion group, with chorus, all did basically better in terms of the VAS with their worst arm pain, the VAS neck, and the neck disability index. And I think it goes along with basically the idea that if you are trying to achieve a fusion, you're going to have better outcomes if you actually achieve a fusion. And I think this is definite data to support that. When you look at the quality of life and satisfaction at interim analysis as well, the both groups did reasonably well, but definitely higher patient satisfaction after achieving a solid fusion. When you look at perioperative metrics in the FUSE study, of course, adding posterior fixation to your ACDF construct is going to take a little bit longer. In this case, it was about a 45-minute longer. That's patient positioning, flipping them over, and actually inserting the chorus fixation. But in the grand scheme of things, not that much longer. Blood loss was very minimal. For anyone who has tried this procedure, the blood loss tends to be very, very minimal. Once you get used to doing these procedures, actually flipping over the patient and doing it probably less than 45 minutes. I would say I can set this up in probably more like 20 minutes. It does take a little bit of setup, though. It's no different than an ACDF for most people, just kind of upside down. In terms of length of stay in the study, it was no different. The patients basically stayed overnight and went home the next day. So the key takeaways, in my eyes, this is really a landmark study. Not only did we show the success of chorus and its addition to these high-risk patients, which was huge difference in the fusion rate and a good difference with the overall patient-reported outcomes, but also it showed really how maybe our ACDFs aren't as good as we thought they were. The study showed less SAEs when you get a solid fusion, and the patients had markedly decreased risk of having additional surgery, which none of us as surgeons like to take our patients back for additional surgeries because the first one didn't work. So for me, this study has been pretty eye-opening, and I've changed my practice. In the vast majority of my patients now that are undergoing 3 and 4 level ACDFs, I'm adding this fixation because I know based on the data we've collected in this study that they're going to have better outcomes. This slide basically says the same thing, just maybe a little more concise.
Which is where